The Subcommittee on Health, Employment, Labor, and Pensions will come to order. I note that a quorum is present, and without objection, the chair is authorized to call a recess at any time. President Ronald Reagan once said, "The 9 most terrifying words in the English language are, 'I'm from the government and I'm here to help.' The government often causes more harm than it does good, and that is particularly true when it comes to health care. Thankfully, America is filled with innovators and problem solvers, and today we'll hear from some of those leaders on these important topics of lowering prices for quality health care. The cost of health care is one of the greatest challenges our country faces. Last year, health care spending reached $4.5 trillion, costing over $13,000 per American citizen. Meanwhile, Medicare is set to become insolvent by 2031. In 2023, federal subsidies for health care insurance are estimated to be $1.8 trillion, or 7% of our GDP, or gross domestic product. This has led to premiums drastically increasing for commercial insurance. The other side doesn't seem to understand that when the government subsidizes something, it actually becomes more expensive. It merely shifts the cost from the patient to the taxpayer. In my district in Campbell County, Virginia, premiums for a family plan have increased 81%, or $9,000 over the last decade. So much for the claim that premiums will go down with the Affordable Care Act. The Biden administration's plan is to increase spending and impose more mandates, which will only result in more inflated health care prices, further bankrupting our country. Today, we're going to learn from innovators in the business world who are delivering savings to workers through lower health care costs, while still providing timely access and quality care. Employers not only have a strong incentive to deliver high-quality benefits to retain their employees, but they also have a legal fiduciary obligation to do so. Unsurprisingly, 67% of Americans are satisfied with their employer-sponsored care. But sadly, the system is rigged against employers who want to pursue value-based models. It takes time and resources for healthcare innovators to overcome the significant economic and regulatory barriers in place across the country. We can learn a lot from the witnesses here today, as well as from other innovators who are working to overcome these barriers and teach employers how to use innovative models as well. In 2012, Walmart, the largest private employer in the world, launched its Center of Excellence, or COE program, which directs patients to specific sites and providers for specialty care. Since the launch of Walmart's COE program for spine surgery, Walmart has found that patients who underwent surgery at a COE had a shorter hospital stay and drastically lower readmission rates, and that patients returned to work sooner than non-COE patients. For the 2017 benefits year, it's estimated that Walmart, Lowe's, and McKesson saved $19.4 million through their spine and joint surgery programs. Schweitzer Engineering Labs, which is represented here today, saved nearly $2 million in 2023 by participating in innovative models. California VEBA is also represented here today and has drastically slowed premium growth in its plans, and its beneficiaries have reported a 94% satisfaction rating. The Boeing company also engages in direct contracts with doctors and health systems, effectively bypassing insurance companies. One study found that patient cost sharing decreased expenses per procedure by $498 for orthopedic and surgical procedures when using the direct contract model. However, many barriers still exist, which make it especially difficult for small and mid-sized employers to use these models. One barrier is a lack of data. Employers often struggle to access their own health plan and spending data from their third-party administrator. Without this information, employers and providers are unable to adequately design innovative payment methods and assess quality and savings. Another barrier is the overzealous state regulators who threaten to prohibit or overregulate payment models that allow for provider risk sharing, even when the payment is between a self-funded ERISA plan and a provider. Some states even try to regulate these self-funded ERISA plans as insurance carriers. Furthermore, inconsistent quality measurement standards pose a challenge in the healthcare market. The lack of reasonably established cost and quality benchmarks can be a challenge for employers, providers, and third-party administrators. These barriers often translate into administrative burdens, costing time, money, and personnel to navigate and overcome. These are administrative burdens that many small and mid-sized companies do not have the resources to cover. One solution would be to allow employers to take advantage of economies of scale by permitting them to join together in one direct contract with a provider. Another solution could be to strengthen data sharing requirements, as this committee has done in the provisions included in the House-passed Lower Cost, More Transparency Act. The federal government could also clarify that ERISA self-funded plans can participate in innovative payment models without being targeted by overzealous state regulators. These are just a few of the ways to address barriers employers face today. Our witnesses will speak more about the different challenges and solutions that Congress can consider when providing space for our healthcare innovators and business owners. I look forward to today's discussion and seeking ways to create more pathways for lower cost, high quality, and innovative healthcare. And with that, I yield to the ranking member for his opening statement.
Thank you, Mr. Chairman, and welcome back, everyone, to this committee and the Congress. Hope you had a wonderful holiday break, Mr. Chairman, and everyone. While I'm interested in hearing from the witnesses today about the work that some employers are doing to foster innovation, and as I have often said, I'm agnostic in some regards to healthcare, well, in many regards as a consumer, unfortunately, of healthcare. In the last few years, as a survivor of cancer and 4 weeks on a ventilator, I see the inefficiencies in our current system, personally and professionally. I also think that when you look around the world, holding Walmart up, Mr. Chairman, with all due respect, is sort of a model I can't disagree with more. What a paradise on earth. We all could be Walmart employees as a former small business owner who had to deal with them. There is a mixed market, and the rest of the industrialized world either has, like the British, a full public system of healthcare, or a mixed, like the Japanese and the Germans. And so if we can show some place that actually works with a complete free market, I'd be interested in seeing how that works, and perhaps somebody can enlighten me today to that model. 14 years ago, President Obama signed into law the Affordable Care Act, an innovative, that seems to be the word of the day, piece of legislation that has reduced the uninsured rate to the lowest level in American history. Before the ACA, by law, insurance could deny people with health care coverage because of pre-existing conditions, including pregnancy, substance abuse disorder, and even cancer. Insurers could also charge a woman more than men for health insurance. What was once considered an out-of-reach privilege for many Americans has turned into more than 20 million consumers projected to sign up for the coverage during this year's open enrollment period, a dramatic increase over last year's record enrollment. Congressional Democrats and the Biden-Harris administration continue to build on the ACA and have made historic strides towards patching remaining loopholes in our healthcare system and expanding high-quality healthcare coverage for Americans. Quality insurance for health is very important, not just cost. In 2021, congressional Democrats passed the American Rescue Plan, which enhanced the ACA tax credits to lower monthly costs for low-income individuals and eliminated the subsidy cliff so that more low and moderate income individuals could get coverage. In 2022, congressional Democrats passed the Inflation Reduction Act. This historic legislation extended the premium tax credit enhancements, capped the cost of insulin for people with Medicare, and for the first time directed the federal government to negotiate lower prices for prescription drugs covered by Medicare. Democrats have demonstrated that innovation, there goes that word again, provides relief to workers and families from the burden of excessive health care costs. Unfortunately, many of the bills proposed by my friends on the other side during the current Congress would undermine, in my estimation, affordability and quality of care, and ultimately make it harder to access quality coverage. For example, expanding association health plans might provide lower premiums for some enrollees, but it would increase costs for other consumers in the traditional insurance market while adding nothing to address the underlying price of health care. That is a bad deal for American workers and for small business. The idea of scale for small businesses is one that I would appreciate exploring more, but the devil is in the details. And I've heard many of my colleagues call to repeal the drug price negotiation program outlined in the Inflation Reduction Act. Repealing this program would reverse the hundreds of dollars in savings on out-of-pocket costs that those in Medicare have benefited from. Similarly, I'm concerned that everyday Americans are increasingly being pushed to adopt unregulated, low-quality junk healthcare plans. These plans often discriminate against people with pre-existing conditions, like myself, do not cover essential health benefits, and raise costs throughout the healthcare system. Instead of encouraging counterintuitive policies, we should work together in good faith, recognize our differences in approach to focus on expanding quality health coverage for all Americans, workers, families, employers, and their employees. Together, we can strengthen the Affordable Care Act to expand access to quality health care by lowering prescription drug costs for all Americans. Last July, House Democrats introduced the Lowering Drug Costs for American Families Act to rein in pharmaceutical price gouging and reduce prescription costs for Americans with private health insurance, including those covered by employer-sponsored health plans. It is also worth noting that similar legislation passed by House Democrats during the 116th and 117th Congress would have slashed premiums and cost sharing for privately insured individuals by as much as $53.8 billion, saved American businesses $43.1 billion, and raised workers' wages by $116 billion. In short, when employers save more, employees take home more. This is good for everyone, including the American economy, as they have more disposable income to spend. This is the innovation we should strive for. With that, I want to thank you again, thank the witnesses, and look forward to the discussion.
Thank you to our ranking member. Pursuant to Committee Rule 8C, all members who wish to insert written statements into the record may do so by submitting them to the committee clerk electronically in Microsoft Word format by 5 p.m., 14 days after the date of this hearing, which is January 24, 2024. And without objection, the hearing record will remain open for 14 days to allow such statements and other extraneous materials referenced during the hearing to be submitted for the official hearing record. I'll now turn to the introduction of our distinguished witnesses. Our first witness is Mrs. Michelle Beeler, who's the Senior Director of Health and Wellbeing for Schweitzer Engineering Laboratories, or SEL, which is located in Pullman, Washington. Welcome. Our second witness is Miss Laura Josh, who's the General Manager of California Schools Viva, which is located in San Diego, California. Welcome. Our third witness is Miss Andrea Dukas. Andrea, who is the Vice President of Health Policy at the Center for American Progress, which is located in Washington, D.C. Welcome. And our final witness is Dr. Christopher Whaley, who's the health economist at the RAND Corporation and who's located in Providence, Rhode Island. We thank all of our witnesses for being here today and look forward to your testimony. Pursuant to the committee rules, I'd ask that you each limit your oral presentation to a 5-minute summary of your written statement. I'd also like to remind the witnesses to be aware of their responsibility to provide accurate information to this subcommittee. First, recognize Ms. Beeler for 5 minutes.
Chair Good, Ranking Member DeSaulnier, and members of the subcommittee, thank you for holding this important hearing. Thank you for the opportunity to testify. I'm Michelle Beeler. I'm the Senior Director of Health and Wellbeing at Schweitzer Engineering Laboratories, SEL. SEL was founded by Dr. Edmund Schweitzer over 40 years ago in the basement of his home in Pullman, Washington. We are a proud 100% employee-owned American company, researching, designing, and manufacturing right here in the U.S. At SEL, we specialize in creating digital products and systems that protect, control, and automate power systems here at home and in 170 countries around the world. We make power outages safer and shorter in duration. We add cybersecurity, automation, and communication to critical electrical infrastructure. We have over 6,500 employee owners worldwide, nearly 10,000 covered lives in our U.S. healthcare system, and we have a presence in 37 states around the country. At SEL, we are rooted in a set of values that we call our principles of operation. These principles guide us, and in the words of Dr. Schweitzer, they help us to run our business the way our mothers would want us to. Central to these principles are the ideas of ownership and community. When it comes to healthcare, we believe we should own our claims data and we can make the best and informed decisions and meet our fiduciary responsibility to our employees and their families. We strive to empower employee owners to take ownership of pricing and quality information to make the right choices for themselves and their families. We believe in strong community partnerships, especially with our local hospitals, to take ownership and work towards lower cost and higher quality care. This drive for ownership inspired SEL to start our own health clinics over 10 years ago to serve employee owners and their families. SEL now has 2 health clinics in the United States, and in 2023, these clinics completed over 20,000 patient visits. Our medical staff includes a doctor, nurse practitioners, nurses, physical therapists, mental health professionals, and a pharmacist. We provide convenient access to high-quality, comprehensive primary care services at no out-of-pocket cost to our patients. We deliver high-quality and patient-centric care with virtually no wait time and at similar or lower costs than other clinics. We've removed barriers when it comes to seeking care. With a simple walk across the parking lot, our employee owners can see their healthcare provider. We are proud of our work and support in the mental health space as well. We offer in-house counselors, a robust employee assistance program, and free virtual counseling services for all employees and their families. We're excited about the continued growth of our pharmacy program, which has consistently delivered savings while improving patient care. SEL has a physician dispensing pharmacy with medications such as antibiotics and dosage-starting drugs. We counsel our patients on drug interactions and help patients review their prescriptions to look for ways to save on lower cost options like generic drugs. Recently, by working with just 25 individuals to help them identify low-cost sources for their medications, we will likely reduce our annual pharmacy care spend by 25%. Let me share with the committee just one example of the positive impact your policies are having on individuals. Recently, we worked with an employee owner taking a drug that cost nearly $10,000 per month, with an out-of-pocket cost of nearly $3,000 per month for them. Sadly, the employee was taking on mounds of credit card debt and struggling to pay for basic needs like groceries and utilities just to pay for this medication. In utilizing our in-house pharmacist, we identified a generic equivalent on Mark Cuban's Cost Plus Pharmacy for $12.80 a month, saving the employee nearly $36,000 a year in out-of-pocket expenses and saving SEL an additional $84,000 for a total savings of $120,000. That's the power of transparency. In addition to improving our healthcare and benefits offerings within SEL, we also began to work with external partners, like our local hospitals and providers, through direct contracting. On the policy front, the No Surprises Act, specifically Section 201, has been tremendously helpful, providing us with critical access to claims. This law, along with others, has given us more valuable and useful information about the market, equipping us with the right tools to find the price that is both fair and reasonable for SEL and the provider as well. Thank you again for the opportunity to testify today.
Thank you, Mrs. Beeler. And I'd now like to recognize Ms. Josh for 5 minutes for your opening statement.
Chairman Good, Ranking Member DeSaulnier, and distinguished members of the committee, thank you for the opportunity to appear before you today. My name is Laura Josh. I'm the General Manager of California Schools VIBA. VIBA was founded in 1993 through the combined efforts of school superintendents and representatives of the California Teachers Association and the California School Employees Association to combat rising healthcare costs in Southern California. Since then, we have grown to more than 70 participating public sector employers, including 4 of the top 10 largest school districts in California, as well as the County of San Diego, with more than 150,000 covered members in our plan. We are now the 4th largest purchaser of healthcare in the state of California. VIBA strives to leverage our collective purchasing power to keep health premiums low and ensure access to comprehensive benefits designed to keep employees physically and mentally healthy. As a 501c9 nonprofit healthcare trust, all funds are spent on member benefits and health improvement, and we are governed by a board that represents both labor and management. As fiduciaries, the heart of every decision we make is our members, which are our teachers, our custodians, our transportation workers, and other staff who have dedicated their professional lives to educating future generations. We strive for the highest quality benefits at the lowest possible cost to keep more in each worker's paycheck and drive as many tax dollars as possible to student education. This is our motivation to innovate and keep costs low. VIBA consistently beats national averages with annual aggregate premium increases around just 4 to 5%. Additionally, in a recent member survey, VIBA delivered a 94% member satisfaction rating. The trust and satisfaction that we've built over the past 3 decades has enabled us to think more about the long-term cost drivers of healthcare in a more creative and personalized manner. But in order to drive innovation that will reduce healthcare costs, 4 critical things are needed. First, transparency. True transparency enables you to know where every dollar is going and ensure that it is fully utilized. This is one of the primary reasons VIBA is working to remove regulatory barriers to direct contracting in California, and we are the first to participate in a groundbreaking pilot that directly contracts with health systems using risk-bearing contracts. Transparency also helps us ensure incentives are aligned across the healthcare industry, so providers, payers, and purchasers are all singularly aligned on improving population health and treating each patient holistically, meeting both their physical and mental health needs. Second, competition. We need robust competition in the healthcare market to drive down costs. Having visibility into our contracts through the direct contracting pilot will facilitate this competition, drive more effective cost structures, allow for greater innovation, and give the consumer more visibility into their care options. Third, market power. While we've seen significant consolidation in the healthcare industry, many purchasers remain fragmented and trying to negotiate on their own. Policies that allow purchasers to come together and navigate the market jointly will help drive down costs. And finally, removing barriers to innovation. VIBA worked closely with state regulators to enable our direct contracting pilot, but barriers still exist that prevent us from further partnering with small businesses or enabling organizations in other states to benefit from these important direct contracting models. At VIBA, we have successfully fought the rising costs in healthcare through innovative patient-focused care and quality programs. VIBA and other purchasers can achieve quality care at lower costs and build on our success if Congress takes the following actions. First, remove barriers to employer participation in value-based programs such as high-performance networks and direct contracting. Next, increase transparency into healthcare claims and encounter data, along with information on costs and quality for healthcare providers. Next, ease federal and state restrictions on pooling with appropriate protections for small employer groups to bring the VIBA value to other employers. And finally, invest in our pipeline of critical mental health workers and other healthcare professionals. I look forward to discussing with the committee how we can work together to bring more patient-centered innovation to the employer marketplace using direct contracting, improving transparency, leveraging group purchasing, and cementing a commitment to cost reduction while improving the health of our members. I look forward to your questions.
Thank you, Ms. Josh. And now we recognize Ms. Stukas for 5 minutes for your opening testimony.
Thank you to the subcommittee for your attention to this critical issue. I'll begin by acknowledging the squeeze employers are facing when it comes to providing affordable coverage. This phenomenon is not new. I know it well from my time working at a small nonprofit back in 2009 before the ACA. We had around 50 employees, the vast majority of whom were women, and several of whom had kids or were pregnant in the past year. It was close to impossible to keep premiums manageable. I knew healthcare, so was asked to help find a solution, and what we wound up with, even then, was an exclusive provider product with no out-of-network coverage. I applaud the employers who are doing what they can to bring costs down on their own while trying to do right by their employees. Some of the innovations being discussed today can even be successful for the businesses who invest the considerable time and resources to developing them. Unsurprisingly, though, only small numbers do. And there are limits to success, considering the headwinds of healthcare consolidation and high prices. Employers, instead of being responsible for bending the cost curve, should be able to focus on their core business. I'm passionate about health policy, and I would have liked nothing more 15 years ago than to focus on my day job. Which brings me to today. Today's ESI products are significantly better than they were back when we were negotiating with our broker, thanks to the ACA. At that time, people were subject to pre-existing condition exclusions, coverage limits, cost sharing for preventive services, and many other challenges that the ACA eliminated. When people lost their jobs, they also didn't have the ACA marketplaces to fall back on, and thanks to ARPA and the IRA, the enhanced premium tax credits to make that coverage even more affordable. The difference could not be more pronounced. As I acknowledge, however, it is difficult for employers to affordably provide that coverage. Premiums, which have been growing faster than inflation and wages over the last 25 years at least, are now close to $9,000 for a person or $24,000 for a family. Perhaps even more troubling is the increased out-of-pocket expenses employees are responsible for as employers cope by shifting costs onto them in the form of higher deductibles. As a result, about 30% of workers are considered underinsured. This stubborn cost growth is primarily a function of high prices. From 2017 to 21, prices for healthcare services grew at almost double the rate of utilization. And those prices are primarily driven by two things: consolidation, which in particular drives up hospital prices, and exorbitant prescription drug prices. Employers understand this, and they want relief. Close to 90% of surveyed business leaders believe there should be greater government role in providing coverage and containing costs. They believe, correctly I might argue, that a bigger government role would be better for their businesses and for their employees. 90% of business leaders want to see more government intervention to increase transparency. We agree, and strongly recommend congressional action to establish a federal all-payer claims database, or APCD, which could make healthcare claims data available across payers and enable employers of all sizes to make informed choices about which providers to contract with, also encouraging providers to lower their costs. More than 90% of those leaders want greater action against anti-competitive behavior. That makes sense considering how problematic healthcare consolidation is becoming. Consolidation can increase the price of hospital stays by as much as 54%. Consolidation within the insurance market is also rapidly increasing, as is consolidation across entity types. It may surprise you to know that United Health Group now purportedly owns or is affiliated with 10% of all physicians in the United States. That's 90,000 doctors, 20,000 of whom were acquired or affiliated with United within the last year alone. While largely outside of the scope of this subcommittee, we strongly encourage congressional action for more expansive monitoring of this kind of behavior. To help lower drug prices, Congress can also build on the historic Medicare prescription drug pricing reforms established through the Inflation Reduction Act and bring innovations such as the Medicare Drug Price Negotiation Program and inflation rebates to the commercial market, as the Lowering Drug Costs for American Families Act would do. These innovations are estimated to save the Medicare program billions of dollars. There's also bipartisan interest in lowering drug prices by closing the loopholes that are regularly exploited by pharmaceutical companies, like patent system abuses and stalling tactics to keep generics from entering the market. And we implore Congress to pass legislation to do that. We also encourage congressional action on bipartisan proposals to regulate pharmacy benefit managers that profit when drug prices are set as high as possible. I highlight a number of those opportunities in my written testimony and appreciate the subcommittee's engagement on this issue. Finally, Congress can consider bolder reforms, for example, exploring the introduction of an employer public option as an alternative to current ESI offerings. Congress has the ability to provide relief employers want and need to help ESIs become more sustainable and affordable for the years to come. Thank you again.
Thank you, Ms. Dugas. And now we'll recognize our final witness, Dr. Whaley, for 5 minutes for your opening statement, please.
Thank you. Chairman Good, Ranking Member DeSaulnier, and members of the committee, thank you for the opportunity to testify today. My name is Christopher Whaley. I'm a healthcare economist at the nonprofit, nonpartisan RAND Corporation, as well as an associate professor of healthcare policy at the Brown University School of Public Health. My research in general focuses on healthcare price transparency, the impacts of evolving healthcare market structures, and importantly, the role of employers' purchase of healthcare benefits and many innovations that employers are doing as purchase of healthcare. Employers play a significant role in the United States healthcare system. Employers provide health insurance coverage for over 150 million people, the largest source of insurance in the United States. Employers also importantly select many of the plan offerings that employees select from, thus determining the types of insurance that most Americans have. Collectively, U.S. employers contribute about $1.2 trillion towards healthcare spending and thus play an important role in financing the U.S. healthcare system. Because healthcare benefits are financed from wages, employers have both a legal and a moral obligation to be responsible fiduciaries when they are purchasing healthcare benefits on behalf of their workforce. Unfortunately, many employers face challenges fulfilling this obligation. Many employers are unable to access their plan claims data, limiting their ability to audit and negotiate, or audit prices and negotiate on their behalf, as well as prudently designed plan offerings. Employers often face consolidated provider markets with limited access to lower price, high quality providers. Due in large part due to decades of consolidation among providers and plans that has driven down competition, prices paid by employers are often high and variable, with little to no link between price and quality. However, a handful of employers have used benefit design innovations to reduce spending and improve access to high quality care. These programs typically use price, utilization, and quality data to identify efficient providers that deliver high quality care at lower prices, and then design incentive programs to direct members to these providers. A particularly innovative example actually comes from Purdue University, which has used data on local provider prices and quality to contract directly with high-value providers and incentivize their use. These types of so-called direct contracting plans are often accompanied by negotiations price discounts because providers gain member volume. Due in part to these programs, Purdue has not had employee premium increases in 5 years and has saved approximately $200 million. Likewise, General Motors' direct contract program with the Henry Ford system in Michigan reduced healthcare spending by an estimated 15%. Other examples include reference-based pricing, which tie reimbursement rates to benchmark rates, and have also led to considerable savings. For example, the reference pricing program implemented by the state of Oregon has reduced spending by about $100 million for Oregon teachers and public employees. Due to reference pricing savings, the state of Montana employee plan had no deductible or premium increases for several years. Anecdotally, my father was a member of this plan and certainly benefited from having his pay increase come in the form of take-home dollars and not healthcare dollars. A critical component for an employer's ability to innovate and implement these types of programs is use of transparent data on differences in provider price and quality. Unfortunately, several self-funded employers who want access to their plan's claim data for auditing or monitoring purposes have actually had to file lawsuits to gain access to this type of data. Additionally, access to hospital and insurer-posted price transparency data required by federal regulations that allow employers to comparison shop across providers and plans without placing additional burdens on their members have not been widely useful. These type of data, if further expanded, would allow employers to benchmark their own prices against market rates. In conclusion, whether they like it or not, U.S. employers are in the healthcare business. To be responsible fiduciaries of their members' money, employers need to use data to ensure their healthcare benefits deliver high-quality care at reasonable prices. Federal policy can strengthen employer access to their own claims data and improve compliance and usability of federal transparency policies and data. I'm happy to answer any questions, and thank you for the opportunity.
Thank you, Dr. Whaley. Under Committee Rule 9, we'll now question witnesses under the 5-minute rule. I will wait to ask my questions, and therefore I will recognize Mr. Wahlberg from Michigan for 5 minutes.
Thank you, Mr. Chairman, and thanks to the panel for being here. Very, very important subject we're dealing with today. Ms. Josh, it's my understanding that California Schools VIBA operates as an association health plan. Last year, House Republicans passed my legislation codifying the Trump administration's 2018 rule to expand association health plans. How would expanding AHPs help reduce overall health care spending among employers?
Thank you, Congressman, for that important question. So VIBA operates similar to an association health plan, not exactly as an association health plan, but I think the concept of increased market power is incredibly powerful. So within VIBA, we have employers that have more than 15,000 employees, down to our smallest employer that is a single-room schoolhouse with only 3 employees in the mountains of San Diego. And what I think is most valuable about pooled purchasing is that every employee, no matter which employer they participate at, receives the high quality and lower costs of the broader pool. We're also able to expand benefits in being able to add additional services like enhanced mental health, enhanced cancer screenings, expert second opinions that would be unaffordable or unreachable for small groups outside of the pool.
I appreciate that. And that leads me to the second question. The Biden administration recently proposed a rule to repeal the Trump administration's rule. And their statement as to the reason why they want to repeal associated health plans as implemented by Trump is that AHPs are skinny plans. You just mentioned some significant benefits that come in your plans for your people. Is the Biden administration's characterization correct? And specifically, does California Schools VIBA skimp on coverage for its enrollees?
California Schools VIBA is incredibly proud of the coverage that we offer for our employees. Almost none of our employees have deductibles in their plans. They have $10 copays. Our view on healthcare has always been, if it is unaffordable for the family to use it, the healthcare coverage itself is practically useless. So we're very proud that we've kept the quality very, very high. I compare it to my husband works for a small employer. My out-of-pocket maximum for my family under my plan is only $6,000 a year. His option at the small employer is $13,000 a year. So we're able to offer significantly enhanced benefits relative to what small employers are able to access.
So I'd assume the next issue would be a positive for what you've experienced. I would assume AHPs or similar are effective at reducing health care costs without skimping on coverage?
I believe with appropriate protections and regulations, group purchasing can be a very powerful tool in producing market power for purchasers.
Okay. Thank you. Thank you. Dr. Whaley, in your written testimony, you highlight that, I quote, plan and price data are critical to health benefit innovation. In addition to access to data, are there other barriers that limit the ability of employers to implement direct contracting or similar programs?
Frankly, I think access to data is the number one hurdle. And without knowing what your own prices are, what prices are in your market, it's really impossible for employers to design these types of programs. Secondly, I think just where there's a will on behalf of employers to act as responsible fiduciaries and recognize that healthcare is a huge component of their business and respond prudently and respond in a business-focused fashion.
What could Congress do to eliminate these barriers?
I think codifying that employers have access to their own claims data, if they're a self-funded, ERISA-regulated employer, would be critical and have access in a timely manner. Secondly, I think expanding access to transparency and coverage policies and making sure that hospital-posted data is accurate and timely, and ensure posted data is widely usable.
Jump quickly here, not much time left, but how does the use of telehealth in these models differ from telehealth use in traditional fee-for-service care?
What we've seen in published research studies I've conducted is that providers that are paid in a non-fee-for-service setting, where getting patients in the door is the most profitable source of revenue, actually tend to use telehealth more than providers that are paid in a capitated or value-based manner.
Good to know.
Or, the opposite direction.
Yeah, good to know. Thank you. I yield back.
Thank you, Mr. Wahlberg. I'd now like to recognize Ms. Wild from Pennsylvania for 5 minutes.
Thank you, Mr. Chairman, and thank you to the witnesses for being here for this important hearing. It's a subject I've long been concerned about, even though I feel as though we've made a lot of progress over the last few years. Healthcare costs are still too high for too many Americans. Ms. Dukas, and am I saying that pronounced? Okay. I was very proud last Congress to support the Inflation Reduction Act, which was signed into law in August of 22, which, as I think everyone knows, dramatically lowers the cost of prescription drugs for seniors on Medicare and slashes premiums for people who purchase coverage under the Affordable Care Act, and of course caps insulin prices for millions of Americans. But as I said initially, we haven't done enough yet, and the work must go on to lower these healthcare costs, particularly, I think, for the millions of people who are covered through employer-sponsored plans. And my biggest concern are items that aren't covered in those employer-sponsored plans, including some preventive cares. We know that a majority of Americans receive their health coverage through a job-based plan. and we need to make sure that their healthcare needs are being met. Can you give us an example of some of the basic preventive services that aren't covered through many employer-sponsored plans?
Thank you for the question. As you mentioned, the Affordable Care Act had a provision that required the coverage of essential health benefits, which applied essentially in the group market.
Can you speak up just a tiny bit?
Yes, thank you very much. Thank you for the question. As you mentioned, the Affordable Care Act had a provision that required the coverage of essential health benefits. What I would share, which include things like colorectal screening, annual preventive service visits, but what I would share is that there are many states who are able to regulate insurance within their states that pass laws that require even more comprehensive coverage of different services. Some examples might be, assisted reproductive technologies help that
You
don't
said
necessarily.
assisted reproductive technology?
Yeah, thinking about like IVF, but many plans are self-insured plans that are subject to ERISA and therefore not necessarily subject to those enhanced regulations that require even more access to services.
Right.
I mean, there are a number of services that are not in the essential health benefits that would be especially prudent to be able to incorporate into more employer-sponsored plans. But I'm happy to follow up with.
So there's a lot of variance, you're saying?
There's a lot of
depending on the
variance,
state
yes.
and the employer and the nature of the plan.
That's exactly right.
Okay. I'd like to turn to you, Dr. Whaley. There's, I think, a growing bipartisan recognition that we don't have enough information about costs in the healthcare system. In your testimony, you identify an important issue, which is the lack of transparency from companies that contract with employer-sponsored health plans to administer their benefits, including pharmacy benefit managers and insurance companies that serve as third-party administrators. So can you share with us some of the challenges that plans face when they are trying to get cost information from their PBMs or their third-party administrators? And as part of that answer, could you address what the impact is on healthcare costs?
Yeah, so some self-funded plans, when they ask for their claims data, either for their own use or an entity directed by the self-funded plan to use the claims data, have faced challenges in actually accessing that data. So some large insurers or third-party administrators often argue that negotiated prices and network design contained in claims data are trade secrets, and thus the employer, even though they're the one that's paying the bill, doesn't have access to that type of data. And I think not having that type of access to data doesn't allow the employer to essentially monitor what's going on under the hood and audit the prices that are being negotiated on behalf of both themselves and, more importantly, their workers. And so I think having access to that type of data can greatly allow employers to innovate and address prices.
And would you agree with me that as a capitalist society, competition is important, and that without data on pricing, it's very hard for a consumer, whether it's a healthcare plan, employer, or whatever, to make sure that they are getting the benefit of competition?
That's correct. If we're going to have a system, we need data and competition.
Thank you so much.
Thank you, Ms. Wild, and I'd like to recognize myself now for 5 minutes. Ms. Josh, we've heard today already about the negative impact of consolidation in the healthcare market and its effect on healthcare prices. How would allowing multiple employers to pool together to use one type of payment model help bring more competition to the market and lower prices?
Thank you for that question, Congressman. I think one of the things that we see is consolidation with the healthcare purchasers and the providers of healthcare, whereas individual consumers, we've stayed very fragmented and trying to negotiate against these behemoths on our own. By pooling together the purchasing powers of employers, we start to have the power of volume in negotiation. So when we talk about market power, part of where you really get that market power is being able to go to a local hospital system and tell them you represent 10, 20, 30,000 of their members to get more effective pricing, to get more access to your data, to drive better primary prevention. And so the more in different markets healthcare consumers can come together to purchase together, the more market power you're going to have against that consolidation, which will ultimately create greater competition.
Thank you. And so what other barriers need to be lifted to ensure further access to voluntary employees beneficiary association plans and similar employers pooling?
So there are various requirements around it. One of the existing requirements for VEBA is the type of employer that can participate. We've had many small employers approach us wanting to join and access these benefits, but based on the VEBA regulations, they cannot. There are also various state regulations across the country that require, that will actually look through an association to the underlying size of the employers. So we'd really be looking for a clear definition of the ERISA preemption for a purchasing group to be able to act as that single purchasing entity to consolidate that market power.
Very good, thank you. Dr. Whaley, your research has identified provider consolidation as one of the main drivers of healthcare costs. How would encouraging the uptake of risk-based and other innovative payment models help address the consolidated healthcare market?
One of the things we've seen through especially reference-based pricing and direct contracting is that this is a model that allows for lower-priced, high-quality providers to essentially gain volume and gain patient revenue through offering more competitive prices and being a more efficient provider. And so if you're an independent provider who's efficient, then these types of models actually allow you to remain independent and promote more competition.
Very good, thank you. In your written testimony, you also noted that large employers like General Motors and Purdue University have created savings through direct contracts with high-value providers. What barriers do smaller employers face in entering into similar contracts?
Again, in some sense, the main barrier to these types of models is not the size of the employer, but the ability and innovation or desire to innovate and recognize that they are fiduciaries for their employees. I think for smaller employers, it's often hard to have the market volume within a given market to essentially corral your market power and form these types of direct contracts and especially negotiate better prices. But I think other plans that allow employers to essentially form co-ops or come together can help address that limitation.
Very good, thank you. I'd like to go to Ms. Josh. We have heard today, I'm going to go to Ms. Beeler. You talked in your testimony about the transparency and coverage regulation that's helped you to get data that you need, but you still have data access issues with claims administrators. Can you explain why it matters for employers to have access to data?
Thank you for the question. It's very important for employers to have access and transparency to that data. Without it, we are unable to recognize and see what's happening on our plan. When we received our claims data after 18 months of trying to get it, we were able to find trends, find opportunities and gaps in our plan, find areas in which we can go and direct contract directly with providers to negotiate better pricing, as well as follow through to make sure that our employees and their family members are getting the best prices and the highest quality.
How about from the patient standpoint? How does it help the patients to have access to data? Why does it matter for them?
So we partner both with educating our employees as well with all that we're learning from our aggregate data, as well as providing tools to them such as Healthcare Blue Book so that they can pair both quality ratings as well as price to make the best decisions for them and their family, which directly impacts their out-of-pocket costs.
Very good. Thank you so much. Now I'd like to recognize Mr. Norcross from New Jersey for 5 minutes.
Thank you, Chairman, and to the ranking member for holding this hearing. And it feels like we're just scratching the top grains of sand in a beach dealing with this. But as we all know, it has to start somewhere, and appreciate bringing this up. You know, we all know that access to health care is much more than just that, particularly after coming through the pandemic when so many of the mental health issues reared its ugly head, not of the least, which is the disease of addiction, which has decimated and literally killed over 85,000 people a year. But that all now gets lumped into this. And I hear from each of the testimonies a variation of how not only trying to save money, but expand services. And the very nature of expanding services costs money, whether it's efficient or not. And if we go back 20 years, the idea of what we were spending on mental health as compared to today is just dramatically different. And it adds, just as pharmaceuticals do, adds to the top line. Back in 2008, I believe it was, the Parity Act was passed, which indicates to the insurance companies that you have to treat mental health same way you treat your physical health. One of the issues with that is there is no upfront enforcement of how we deal with that. So, Ms. Dugas, I just want to talk to you. We've introduced a bill in the past couple of sessions called about the Parity Enforcement Act, which instead of where the incentive is now for an insurance company, if they are caught, and I use the term caught, not providing the proper mental health, their penalty is, oh, you'll have to pay it afterwards. But the fact of the matter is, great, we didn't lose anything because we would have had to pay it. By being able to give the Department of Labor the ability not only to investigate, but to levy fines up front on these issues, hopefully that will expand mental health services. And certainly when we look at parity from healthcare, 85,000 people alone dying in just that one sliver called addiction. Will this make a difference? Because you're fighting increasing access to services, but we're saving lives. Can you touch base on the complexity of that?
Yeah, and thank you for the question. I really appreciate it. You highlight a very significant issue, and I would argue gap in coverage. Behavioral and mental health services are very, very difficult for people to access, even with very good insurance. Anecdotally, many friends, family members, and colleagues find it very challenging to use even their employer-sponsored insurance to find an in-network therapist or behavioral health counselor. We know that only 2 out of 3 firms say that there are enough mental health providers in their networks that they offer to their enrollees, and 21% of firms, large firms that offer behavioral health benefits, have limits on those services. There's many complex reasons for this. I think a lot of behavioral health providers are largely incentivized not to contract with insurance because they're paid less than other types of physical health providers. And as a result, people often have to go out of network to be able to access either a therapist, a psychiatrist, what have you. I think having stronger parity enforcement laws are going to be critical so that the onus isn't on the employee or the consumer reporting that they can't access services to then trigger an investigation into the insurance provider. So yes, the short answer to your question is yes, it would make a difference.
Thank you. Dr. Whaley, could you expand on this? Because gaining more access to life-saving, and I'm focusing more on the disease of addiction, is increasing cost to the plan. But in the long term, many people will suggest this saves the plan money by giving earlier access. You're not going into more physical health care issues. Could you touch base on sort of the two weighing issues we're dealing with?
Yeah, so there are probably many areas in healthcare where we have inefficient spending. So if you're trying to get a, say, knee replacement and one provider charges $150,000 and the other charges $30,000, that's a huge increase in spending with little to no quality improvement. There are other areas where we have inefficient underspending, where we should actually probably spend more and devote more resources. Those include things like primary care, and I think importantly, mental health and addiction services.
Thank you. I yield back.
Thank you, Mr. Norcross. Now I'd like to recognize Ms. Chavez DeRemer of Oregon for 5 minutes.
Thank you, Chairman Good, for holding this important hearing today, and thank you to the witnesses for being here. Central to the issue of high quality and affordable health plans is transparency. To make the best decisions, small business owners need to better access what goes into those costs they're being asked to pay. Small businesses have enough on their plate. They shouldn't have to play games with anyone to get the full picture on the cost of health plans they're offering their employees. I've been proud to lead the Bipartisan Health Data Act alongside Congressman Takano and Congresswoman Manning, which is a common sense solution to make it easier for employers to choose affordable health care options. It would strengthen the ability of plan sponsors to access data from TPAs. Such reforms would make it easier for employers to leverage their own data when designing innovative payment models. Some PBMs and third-party administrators are using loopholes to circumvent current law by 1, limiting the number of claims an employer can audit, 2, limiting the number of audits an employer can conduct, 3, demanding the audit be conducted by their own company, 4, hiding indirect compensation received by the service provider for its role in administering a plan, and 5, and demanding that the audit take place on the service provider's premises. The Health Data Act would close those loopholes. And all of us were excited last month to see it pass the House as part of the Lower Costs, More Transparency Act. Ms. Josh, you've highlighted that increased transparency from pharmacy benefit managers would allow employers to better track their drug spending and make sure their payments are being used well, squarely focused on care for their employees. Could you expand on how the Lower Costs, More Transparency Act would help employers reduce those drug costs?
So thank you, Congresswoman, for that important question, and I applaud you on the work that you're doing. I think transparency is an incredibly critical issue here. One of the ways we've really been able to use transparency is understanding both our costs as well as partnering it with quality data from the Office of the Patient Advocate in the state of California to be able to understand the value of the providers that we're seeing. And we think it's really important that you pair both cost and quality together to understand value so that we're able to encourage our members and create opportunities for our members to select the highest value providers. Using that data, we actually created a tiered network that had lower patient costs and premiums for Network 1, where you chose the highest value providers. If you were going to Network 3, where the costs were 180% of the rest of the county average, you actually paid 30% more in your premiums, and you paid 3 times more at the time of the cost of service. Without access to our data, that would have been impossible. In our very first year, it saved our participating employers more than $50 million and delivered higher quality to the members and delivered great member satisfaction.
Great, thank you. Dr. Whaley, I had a question for you, but you've answered it, so you're good to go. I won't make you say it again. So I'm going to go on to Mrs. Beeler. Given your experience in developing innovative healthcare models for employees, are there other policies Congress should consider to promote employer innovation and transparency in healthcare?
Thank you for that important question. So essentially, any policies that can expand access to transparency of our data and in a timely manner will help employers be able to use that information to share with their employees, educate their employees, and make sure that they have the information they need to make good decisions for themselves and their families.
So for Congress, certainty oftentimes is what you all ask us for, right? To lay the pathway. So being in the healthcare industry, on the personal side, I can tell you this: if we're going to offer affordable health care and we're going to have the providers provide for that, transparency is key, and which is what this hearing is about. So thank you for being here today, and I truly appreciate the time that you've given us today. With that, Mr. Chair, I yield back.
Thank you, and we'd now like to recognize Mr. Courtney for 5 minutes.
Thank you, Mr. Chairman. And before I begin my remarks, I'd ask for unanimous consent to introduce an article which was in The Hill yesterday. Obamacare enrollment breaks record for a third consecutive year, which again documents the fact that they've now exceeded 20 million enrollees in qualified health plans, which is 8 million higher than when President Biden took office 4 years ago. Obviously, the more generous tax credits, which does reach some employees of the smallest of small businesses, is providing obviously a real medical home and insurance home.
Without objection, you're now recognized for 5 minutes.
Thank you. And I'd just like to follow up with Ms. Dukas, the question about prescription drugs and the impact that it's having on employer health plans. Again, the state of Connecticut the insurance department just increased premiums this year, and they noted the fact that there's a percentage of premium dollar from like even just 10 years ago. It's gone from 10% of premium dollar to over 20%, and it's headed right towards 30% of premium dollars. Again, the Inflation Reduction Act which again has now put into place a mechanism for negotiating lower prices for prescription drug. The first tranche of 10 medications is now actively under consideration. There's a bill in Congress, H.R. 4895, the Lowering Drug Costs for American Families Act, which would extend that mechanism to small businesses, to private health plans, to working age Americans outside of Medicare. That obviously would be a very beneficial impact, but it just, again, if you could talk about that a little bit, because you mentioned it in your written testimony.
Yeah, sure, I'd be happy to, and thank you for the question. As you mentioned, the prescription drug price negotiation and the inflation rebates in the Inflation Reduction Act are tremendous savings vehicles for the Medicare program. With respect to extending those into the commercial market, one of the analyses for a similar bill, H.R. 3, found that extending drug price negotiations into the commercial market would increase federal revenues by $45 billion over 10 years as a result of decreased subsidies provided by the federal government. So it would be a significant savings driver, yes.
Great, thank you. Ms. Josh, I read your testimony very closely. Again, it's a really impressive program that is happening out there in California. You know, you again alluded to the association health plans as a potential way to, again, expand pooling and lower costs for drugs. But you did mention on page 14 that there has to be appropriate guardrails in that type of mechanism. So would one of those guardrails be that we at least make sure that essential health benefits, which a lot of blood, toil, and tears went into in terms of the implementation of the Affordable Care Act, to make sure that quality health plans are being sold as opposed to what preceded the passage of the Affordable Care Act?
Thank you for that important question. California Schools VIBA has been really committed to making sure we have high quality benefits. I think one of the keys of that and the appropriate protections is that the members of our board are fiduciaries to the individual members. So they have a legal obligation to ensure that they are delivering high quality value to the members under which they cover. We launched our direct contracting pilot that required legislation with the state of California to use a self-funded plan that could use risk-bearing contracts. One of the items within that bill was actually codifying the essential health benefits that would be offered under those direct contracts to ensure and codify that it continued to be high quality and that the fiduciaries were delivering their value to their participants.
Well, thank you for that answer, because again, Mr. Wahlberg, who we've served together for a long time, and I really respect him, but his bill actually allowed for waiver of the essential health benefits in the legislation that that the other side has been pushing forward. And to me, that's a step backwards. And that's where, as a former small employer before I came to Congress, I mean, I get it, that people really by themselves, if you got 6 or 7 employees like I did, you're helpless in the marketplace. So pooling's good. But the fact is that we, as you point out on page 14 of your testimony, if we're going to go that route, we got to make sure that we're at least building in those safeguards and guardrails. And I hope that point is well understood and documented in today's hearing. Because again, I think there's potential for bipartisan movement on that type of issue. But again, we can't just walk away from protections for employees who are going to be patients at some point with these health plans, so that they're getting access to critical care, which was again identified through the essential health plan rulemaking that took place back in 2010. So again, I'm running out of time, but really quickly, you mentioned as a public option for employers, Ms. Duquesne, is again, it's something that Congress should look at. Can you comment quickly?
Yeah, sure. We will be releasing a report in the next few weeks outlining what the contours of that might look like, but essentially it would be an alternative that employers could offer rather than their current ESI offerings, and we outline a number of different designations for that. You would want to sort of have different tiers to preserve employee choice. You'd have government negotiations. Yeah.
Get more choices.
Sure.
Good. So,
More
thank
choice.
you. I yield back, Mr. Chairman.
Thank you. The chair now recognizes Mr. Allen for 5 minutes.
Thank you, Mr. Chairman, and thanks for being with us today and sharing your expertise. Dr. Whaley, as of 2021, Southern Company, located in my home state of Georgia, is the largest utility company in the U.S. in terms of customer base. Its large size has afforded it the ability to stay well below the national average in healthcare costs for the last 10 years, resulting in a cost avoidance of around $15 million annually. Major contributing factor to keeping healthcare costs low for their employees has been their capacity to implement innovative care models such as musculoskeletal centers of excellence, direct contracting through Hinge Health for musculoskeletal, and on-site cancer screenings. Dr. Whaley, unfortunately, not all of employers have the ability or expertise or the resources, particularly small business, to invest in innovative payment models. What types of employers have successfully implemented direct contracting or other innovative benefit designs, and what types of employers struggle to do so?
I think the importance is less on the size of the employer, but more so recognizing that they are fiduciaries and taking that obligation seriously. It may be a challenge for smaller employers, however, to design these programs and just scale these programs if they don't have a sufficient number of patients. There are, I think, many entrepreneurs who are trying to fill the space and essentially pool employer populations and do a lot of that work on behalf of employers.
What would be the impact, for example, in the Affordable Care Act that carved out two groups that got waivers and did not have to deal with the regulatory environment of the Obamacare law? And that was the labor unions and faith-based organizations which offer health care plans. If we were able to carve out, employer-based insurance, and plus under ERISA allow self-employed folks to participate, would that decrease costs substantially?
One example of a purchaser where we've seen loss of innovation actually comes from labor unions. So for example, on the reference pricing program that I've studied in the context of the California Public Employees Retirement System, a lot of the impetus for designing that type of program actually came from labor because they recognize that $1 in healthcare costs comes directly from $1 in wages.
Right. Well, our nation spends twice as much as any of all the other countries average for health care, and the taxpayers of this country in FY 2023 spent $1.6 trillion on health care. And obviously, the health care cost is the driver of our debt, which is now at $34 trillion. And we've got to come up with something to compete with government health care. There has to be two systems. We've seen employers figure this out. In other words, if you leave it, like Ms. Josh, if you leave it to the business community, they're going to take care of their folks. And the reason we have health insurance in the first place was because during World War II, under wage and price controls, the only way you could compete for employees was benefits, and that's when health care was introduced. So, Ms. Josh, if you're given the freedom, in fact, Mr. Whaley, before I leave you, do you know where the dollars are going in health care?
They go all over the place. But to your question, one thing that employers have learned is that it doesn't make sense to pay more for the exact same service if it's done in one setting versus another.
Yeah.
So, for example, Safeway decided to pay for hospital for laboratory tests done in independent settings, and Medicare and others could learn from those types of sites.
Well, we're not going to reduce the cost of health care until we know where all the money's going. At least that's the way we do it in the business world. We take it apart and we say, okay, what can we do, and why is this costing so much money? And all of this started happening when the government got in the healthcare business, and the government owns the healthcare business today. And Ms. Josh, I got 12 seconds. You got anything to add to that?
I think just for small employers, the more market power you can give them, that they can come together, the more able they're going to be able to access these innovations.
And the only way to do that is association health plans.
Or something similar.
And give them the same waiver so they don't have to fool with the government.
so that they could design their programs
Yeah.
to meet the needs of their population.
Exactly. Thank you, and I.
Thank you. The chair recognizes Mr. Scott for 5 minutes.
Thank you, Mr. Chairman. Ms. Dukas, we've heard a lot about association plans. I just wanted to point out that one of the benefits of the ACA is that essentially everybody pays average. In an association plan, you let a low-cost group to pull out, which essentially causes everybody else to pay more. And that's the fundamental problem with association plans. But what happens when some groups can negotiate for lower prices? Do we see other people's prices go up as we do in association plans?
Thank you for the question. Not that I'm aware of. In part, that I think that has to do with transparency. It's often difficult for one employer or business to know that lower prices have been negotiated elsewhere when they have no access to that information. But I would just underscore that you're correct in what you shared about association health plans, and note that there was an actuarial analysis that found that if the Trump administration's association health plans rules had been allowed to go into effect, the self-employed folks that would have left ACA-regulated markets would have been significantly healthier than those who stayed, and that would have caused premiums to go up for those who were not able to leave the market.
Well, if an association formed and found that prices would be higher than the ACA, nobody would buy it. So it wouldn't.
That's right.
It wouldn't work.
That's right.
The only ones that would work were those that could save money, pulling out healthier people. Everybody else, on average, prices go up.
That's exactly right.
There are other things we need to look out for, and that is if a large group can negotiate with a hospital for lower prices. It's one thing if they get lower prices. It's another thing if they're the only ones that can go to the hospital in terms of, and if you have a group of providers, if it's an exclusive group just for them, that could affect the availability for everybody else. Can you say a word about what happens when you have these different groups? I guess one would be that you can't get enough people in your group to cover all the ailments your group may have. And so you're out of network.
Yes. So there, I guess I'll parse that question in two different ways. One would be looking at the market power that some providers have in terms of when they're contracting and executing that market power. If they're the dominant player in a particular place, often they'll use anti-competitive sort of contract terms that might say, hey, if you want to contract with me and send your employees or enrollees to me, you can't send them to our competitor. Or if you want to send them to see some of our providers, you have to send them to see all of our providers. So there's a number of opportunities to address anti-competitive behavior on the part of very large providers. That's one piece. But to your other point around purchasers executing contracts with these types of provider groups, it is very heavily reliant, I think, to do that successfully on having a very large number of enrollees that you can send there. And if there's anything else that would be helpful to expand on, I'm happy to do that.
Okay. We've also heard about the problem with essential benefits. Again, everybody's paying average, but if benefits become optional, then only those that actually need it will sign up for it. What would happen to maternal and child care obstetrical services if that became optional?
That's a very good question. We know that those are two very expensive services and that association health plans are not required to cover essential health benefits. So I would leave that speculation in the air. But I think if I were a plan and had a choice about what to cover, I would look to potentially offload expensive services.
Well, everybody has to pay for a little bit for obstetrical care now. Only people in childbearing age that expect to have children would sign up for it, and that'd become not insurance,
yes,
but prepaid obstetrical care, and they'd be essentially paying the full value.
Yes.
What did removal of the cliff do to the attractiveness of association plans?
Removal of the cliff was associated with many more people on the Affordable Care Act marketplaces qualifying for subsidies. So we saw on average premiums go down about 20% for those folks who were on the marketplaces. Now 80% of people in the marketplaces are able to access a plan for less than up to $10 a month. That obviously becomes a very attractive alternative when you know that those plans are comprehensive and cover all of the benefits you're going to need.
And people could get benefits instead of losing them at about $100,000 for a family for almost $200,000.
Yeah.
Still getting help. Thank you, Mr. Chairman.
Chair now recognizes myself for 5 minutes. Mrs. Beeler, I understand that the direct contracts and the centers of excellence come with, they're encountering geographic barriers issues because really it's just the logistics of having to create contracts with providers, which ultimately means that they're generally to more specific areas. How do you recommend, or have you seen any solutions to expand outside of these geographic areas?
Thank you for the question. At SCL, we've put a number of things in place on our plans to help reach geographical areas and expand services. First and foremost, our on-site health clinic providers are able to consult with any of our members across the country. They may not be able to prescribe or diagnose, but they certainly can provide their expertise and direct people in the right area. In addition, we do also
Is that something that you would like to see changed? So that
Absolutely.
the providers in different states can prescribe and can diagnose and treat?
Provider reciprocity is a huge issue, and we feel it having our own providers. We saw expansion of this during the pandemic, in which many of those barriers came down. From that, we've seen a lot of state PACs come in place that have began to increase access, but the ability to do that much more than just regionally is very important and would provide more care to everyone.
Are there any private solutions, any of consolidating contracts with providers so that it's easier for an employer to directly contract through a group of providers? I mean, we call these networks originally, but they've kind of. But are there any of those within the direct contracting model?
Yeah, so DPCs, direct providers, have begun to network together so that you can access those networks and patients can access those networks and be able to be seen by providers that are licensed in the right area.
Thank you. Mr. Whaley, in your testimony, you noted that the large employers like General Motors, Purdue University, they have saved healthcare dollars through using the direct contracts. Specifically, General Motors' direct contract with Henry Ford Health has lowered its healthcare spending by 15%. And Purdue has saved over $200 million and has not had to raise the employees' premiums over the past 5 years. To continue this discussion, what barriers do you see for the direct contracting?
I think that the one barrier that could easily be addressed is knowledge of both what your prices are now as an employer. So these organizations were actually able to get access to their data and understand the prices that they were paying. But then I think just as importantly, understand the prices across the market.
Mr. You don't think that they understand what check they're writing?
For most employers, healthcare is a black box in which they write a monthly check,
right,
but have very little insight into prices negotiated on their behalf.
Let me ask a question in a different way. I think what's ironic, we talk about price transparency, but it's worth nothing if there's no choice available. Would you agree?
That's right. So
if we're talking about transparency in pricing, but I can think of most of the private sector that we don't have to pass laws to force transparency because they're competitive in their market, correct? We don't have to have a law in place that says that gas stations have to put their price in big, bold letters outside and on highways, but they do it, right?
That's correct. And as I alluded to in my remarks, decades of both provider and plan consolidation.
And I've got short time, but to me, the reason is that there is so much competition. They've got a gas station across the street. But in health insurance, how many carriers are there in the United States?
Well, there's a handful that dominate the market.
5?
Roughly.
5. So the employer, while they could get all the transparency in the world, if you've only got 5 options available, what good is your transparency?
I think that is certainly correct, as well as on the provider side.
I would contend we're trying to get the cart before the horse. I think you provide more choice and transparency follows. That's my contention. Let me ask this. We've been talking about a lot of the demand side. What about the supply side? Have you studied, other states, from state to state, they have occupational licensing laws, certificate of need laws, things that ratchet down the availability of health care. Are there states that do a better job at that and their prices are lower?
I think states without certificate of need laws in general have more access and more choice and lower prices.
Oh, thank you. My time has expired. I now recognize Miss Manning from North Carolina for 5 minutes.
Thank you, Mr. Chair. Thank you to our witnesses for being here today to discuss this critically important issue. I was very proud to support the Inflation Reduction Act in the last Congress, which helped lower costs of prescription drugs for people on Medicare by capping the cost of insulin, and for the first time allowing the federal government to start negotiating for lower prices for certain prescription drugs covered by Medicare. This was an important step, but it's not enough. I am proud to have introduced the Health Data Access, Transparency, and Affordability Act with Representatives Chavez DeRemer and Representative Takano, which passed this committee with bipartisan support because there is agreement that greater transparency will help employers and consumers make better healthcare choices. Mrs. Beeler, have you been able to use healthcare data that you've been able to access in administering your employer-sponsored group health plan to lower costs and improve quality?
Yes, we have. We've had a number of examples both within pharmacy as well as within our own health, bringing in our own healthcare clinics and being able to provide our services in-house and direct contracting with local providers in addition in our communities where we know that there are huge price discrepancies. For instance, advanced imaging is an area, especially in rural communities, where we pay a much higher price than you would see in a non-rural community. And using that information, we were able to direct contract with our local hospital. And in 1 year, we will save over $200,000 in advanced imaging alone.
So greater transparency is one avenue for helping employers and consumers reduce their healthcare costs. Ms. Dukas, as you pointed out in your testimony, despite the efforts that we have made with the ACA, the IRA, and hopefully will make with increased transparency, prescription drug prices have nevertheless continued to rise. While this committee has largely focused on PBM's anti-competitive practices and how they increase costs for employers, it seemed to be a bit of a shell game that we were talking about at that hearing. I think we should also be looking to other points along the pharmaceutical supply chain to lower costs, including the drug manufacturers. You have mentioned that other countries have lower costs for drugs and in some cases better health outcomes than in the U.S. What are some of the tactics that peer nations are using to rein in drug prices beyond price negotiation with manufacturers?
Sure. Well, I would say a key one is price negotiation and caps. I mean, that is critical. Without that, there's little opportunity to bring pharmaceutical prices down. There's a lot of asymmetrical information when it comes to drug manufacturing, and there's also a lot of consolidation and concentration in the market of the suppliers of the materials that go into producing a drug, the manufacturers who produce the drug that are invented, by pharmaceutical companies. So what I would point to is that the primary vehicle for success in other places is their ability to directly negotiate pricing.
And in your testimony, you mentioned that one barrier to lowering costs in employer-sponsored health plans is certain anti-competitive contract terms that inhibit plan designs that could lower costs for consumers. These include all or nothing clauses, anti-tiering, and anti-steering provisions, and other restrictions. If these contract provisions are harmful to workers and raise costs, why do employers or healthcare plans agree to them?
That's great. That's a great question, and thank you for it. The primary reason is because of the outsized market power that the providers that are bringing these contract terms to the table have. So if you are the one game in town, if you are the big name in town, it is a credible threat to be able to say, if you want to contract with us, you have to play by our rules. Because if you're not in the network that you're offering your employees, that's being offered to your employees, if the biggest hospital or the biggest, most recognizable hospital in a particular place is out of your network, your employees are not going to be happy.
And what's the solution to that?
Greater regulation of anti-competitive behavior.
Thank you. My time is about to expire. I yield back.
Ms. Hayes, you're recognized for 5 minutes.
Thank you. Healthcare costs in the United States are the highest in the world, accounting for $4.5 trillion in 2022. In my home state of Connecticut, we rank 9th in the country for per-person healthcare spending. Employer premiums in Connecticut are significantly higher than the national average. Individuals covered by private health insurance plans, including employer-sponsored plans, are billed at rates much higher than what Medicare, Medicaid, and other public programs pay for the very same services. Ms. Dukas, why is it so difficult for employers to reduce how much they pay for health care?
Thank you for the question. A large reason for that is not having sufficient market power to be able to push on that. You're correct that on average, commercial insurers pay significantly more than Medicare for the same services. There can be pretty tremendous variation. One of my co-witnesses has done a lot of research into this. In states with more competitive markets, you see less of a differential. But to answer your question, when you're negotiating on behalf of a very large pool of individuals, as you are with the Medicare program, you can achieve greater economies of scale.
So what can we as policymakers do to lower the cost for Americans covered by private insurance?
I think one of the things that we could do is level the playing field between purchasers and providers. And as we've discussed, there is heavy consolidation in the healthcare provider market and also in the insurance market. So one way to do that is to tamp down on that behavior, reduce the market power that those entities have, which tip the scales a little bit more in the favor of private purchasers. And then another issue, as I've mentioned, is prescription drug pricing. So doing more to regulate prescription drug price, to bring those down, to make it more affordable for employers to be able to offer coverage that covers those comprehensively as well.
Absolutely, and I think that this committee and the Congress are uniquely positioned to do that and not leave it up to employers to have to try to figure that out on their own. I can tell you that House Democrats have been dedicated to addressing the healthcare crisis for over a decade. And as we've heard over, and I'm sure you're aware of, the U.S. Department of Health and Human Services announced yesterday that more than 20 million people have selected an ACA health insurance marketplace plan enrollment. I've seen the numbers in my state skyrocket. There's a record number of enrollments all around the country. So while there are still issues that we have to address, the plan is working. As you mentioned in your testimony, the ACA improved healthcare benefits and strengthened consumer protections for more than 178 million Americans and employer-sponsored insurances. Ms. Dukas, you also mentioned additional action to address the underlying drivers of healthcare cost growth. What are some of the most important consumer protections under the ACA that have made coverage more affordable, and how can we continue to build upon that work today?
Thank you for the question. So some key ones were getting rid of annual and lifetime limits. So prior to the ACA, there were about 105 million people who were in plans that had lifetime limits, and 20,000 people hit those limits each year. So for those folks, the Affordable Care Act meant the difference between bankruptcy and financial solvency. I would say another key protection was also enabling dependents to stay on their parents' plan up to the age of 26, which made affordable health coverage possible for a lot of young adults in this country. Also, the provision of essential health benefits was fairly key. I mean, it is a night and day difference today in terms of what you're able to purchase either on your own or through employer-sponsored insurance, thanks to the ACA.
Well, thank you. I appreciate that. And this is an ongoing debate. We've heard in the last week on everyone's platform a resurgence of conversations about the Affordable Care Act and the benefits or lack thereof, the plans. As my grandmother would say, don't throw out the baby with the bathwater. We have to figure out what works in the plan, many of the things that you just said, and then improve upon the things that don't work. But I think it is a dangerous proposition to go back to a place where we are insuring less people and not more in the United States of America. With that, I yield back. Thank you.
Thank you, Ms. Hayes. I now yield myself 5 minutes. Dr. Whaley, in your written testimony, you describe your research as, quote, studying innovations that employers are making when they have access to price information, end quote. As you know, the House recently passed the Lower Cost, More Transparency Act, which gives employers greater access to their own data and price information. How will this legislation benefit employers who are engaging in innovative payment models?
What we've seen so far is that it's really the frontier of employers who have been able to get access to their own data. And I think that's largely just because traditionally it's been such a Herculean task to get access to data. I think expanding employer access to claims data, as well as having market comparisons through the transparency and coverage policies, will actually allow more employers to participate in these types of innovations.
Thank you. Ms. Josh, I'm very impressed by California's VIBA's ability to reduce costs for workers while maintaining robust access to high-quality benefits. Your written testimony states that VIBA faced challenges standing up its direct contracting model because of restrictions on the use of risk-bearing contracts in your state. Can you elaborate on the regulatory challenges you faced when implementing VIBA's direct contracting pilot programs?
Thank you for the question, Chairwoman. It's one of the items that we think is critical when you look at innovation is aligning the incentives of the health systems and the provider groups with those of the purchasers. And really, at the end of the day, that's are we both investing towards making the population healthier and ensuring they have the services that they need. One of our key tools is called capitation, which is a risk-bearing contract that allows the group to also take downside risk as well as upside risk in the management of the population. In the state of California, if you are to direct contract, you can only do it on a fee-for-service basis. We were required to run special legislation to be able to get the ability to run a pilot to use capitation in direct contracts. Fortunately, it's been a 5-year journey. We have successfully enrolled members in that starting January 1st. But for others to access it, both in California and outside of California, we would be looking and hope for support in clarifying the ability to use those contracts on a direct basis.
Thank you. Ms. Beechler, in your written testimony, you described challenges obtaining claims data and navigating the complexity of our healthcare system when creating new benefit designs. Could you elaborate on these challenges and how they have affected your efforts to improve healthcare access and affordability?
Thank you for the question, Chairwoman. Our attempt to get claims data started years ago. Really, since the passing of the No Surprise Act, were we able to make any traction. But still, at SCL, we went through an arduous process that lasted over 18 months while we tried to get our claims data, both in discussions with our third-party administrator as well as back and forth with data submissions that weren't complete in nature. So this shouldn't be the norm. That shouldn't be the expectation. Also, during this process, we were informed by our TPA that we were the first one in our state that had asked for this level of data, and that also shouldn't be the norm.
Well, thank you very much. I am in a rare situation where I can yield back time. Now recognize the ranking member, Mr. DeSaulnier.
Madam Chair, I will take your time.
Okay.
No, I'm only kidding. Thank you so much. Thank you all for being here. I can't help but think of the possibilities that we have to work together on evidence-based research. Dr. Wiley, that you've been involved with that is bipartisan, that improves the life for consumers. I made a comment about innovation, being a member from the San Francisco Bay Area, and then dealt with innovation with tech industry. It was a wonderful thing until people whose vested interest was primarily return on investment for the investor without a consideration for the consumer. And then innovation just became an excuse, in my view, for some of the downsides. Pardon me for that editorial comment. Ms. Dugas, maybe you could just briefly talk about some of the things that we could do based on what you've heard at this hearing with the Affordable Care Act right now to improve the quality of care, that balance between quality assurance and cost.
Sure, thank you for the question. Well, I think we've heard a lot about the need for transparency and for employers and others to be able to actually see how much they're spending on care, where their money is going. So one of the things that I highlight in my testimony would be to establish a federal all-payer claims database that would allow everyone to be able to see where what their claims look like across payers, and would essentially be a place for both self-insured and fully insured employers to go and to bring their data into as well. I think also looking to, we talked a bit about the enhanced premium tax credits. It would be great to see those made permanent, given the impact that they're having on the Affordable Care Act marketplaces. And then I think in addition to building on the ACA, Congress has a key opportunity to build on the IRA and the prescription drug pricing provisions and inflation rebates therein, extending those to the commercial market and making those really powerful tools work for everyone in this country.
Thanks. Josh, thank you for all your great work as a Californian, albeit from Northern California. You have a unique partnership where you have CTA and administrators working together. But the challenge, and you mentioned you avoid high deductible. Well, the question is for you to elaborate on that, but also the quality assurance. Yesterday I got a call from a dear college friend who has literally a family practice he inherited from his father in Bethesda, and he was telling me about how difficult it is for him as a primary care physician, where his clients will come in, they have health insurance, and then they spend hours, both his staff and his patients, trying to get what they believe the insurance company is required to give them for prescriptions, and then they go out and they give up and they pay out of pocket. How do you handle that in addition to high deductible?
So on the cost, like I said earlier, we've always believed that our members need to be able to afford to go to see the doctor. We can't give them a health plan. And we're covering gardeners, bus drivers, lunchroom workers who make $30,000, $40,000 in California. So it's important to keep the cost of coverage really effective for them. And we drive that through high quality. One of the things that California has a great advantage on is the Office of the Patient Advocate, which is run through the state of California. It is an independent quality monitoring tool that we can use, because we often see if someone has skin in the game, if it's a carrier or someone else determining the quality, you can get differing messages. What we really like in having that independent quality measure is that there is no incentive to drive business or membership one place. So we'd really encourage access to that data, access to that quality information to be more broadly available, because it's been very useful in California.
I remember it well as a former chair of the Budget Subcommittee on Healthcare in the State Senate. Mr. Wiley, you mentioned Safeway. I have a constituent who's the former CEO of Safeway, Steve Bird. Talked to him many times about prevention. So he had some difficulty with some of my friends and the retail clerks over that. But can you talk a little bit about prevention, and to the degree you could include behavioral health, which was also a big issue for those contract negotiations?
So as I mentioned earlier, there are probably many areas in healthcare where we spend too much and spend inefficiently. But at the same time, there are many areas such as prevention and particularly mental health and addiction services where we probably spend too little, and I think it's actually important for health of employers and populations to actually spend more and devote resources to those services.
Thank you, Madam Chair, and I will gratefully now give you time back. Oh, I'm going to do that one close. I just gave you 3 seconds back, Madam Chair.
Thanks.
It's a biblical number.
You want to do yours, and then you do yours, and I'll do mine.
For any newcomers, this is a comedy routine we have that we both think is funny. I don't know if anyone else does. Thank you, Madam Chair, and again, thank you for you, Chairman Good, and the witnesses. I think this could be a really productive hearing. It's in the best interest of American consumers. I'm shocked that in spite of everything, we're still at almost 18% of GDP in terms of percentage of GDP is healthcare costs, and we don't have the outcomes that would, in spite of everything we've tried to do, as opposed to our global competitors, who I think the Japanese are the next closest, and it's 10%, and they have better outcomes. So we can do things that extend people's lives in this country if we work together. Madam Chair, I'd like you to ask unanimous consent to enter the following documents into the record: a letter from the California Public Employees Retirement System and a letter from the American Federation of County, State, Municipal Employees.
Thank you, Mr. DeSaulnier. I ask unanimous consent to submit the following letters into the record from Transcarent, ATA Action, ERIC, Purchaser Business Group on Health, and the Partnership to Advance Virtual Care. Without objection, so ordered. Without objection on yours. Do you have any other closing comments?
No, unless you want me to continue to talk, Madam Chair.
That's okay.
I'd be happy to yield back.
That's all right.
I thought you'd say that.
Well, as you can tell, Mr. DeSaulnier and I get along very well, and this is a very bipartisan issue, and we have worked very hard in this committee, and I'm particularly proud as the chair, and the ranking member's already left, but we have really worked closely on this issue. And now I'll share my prepared remarks. Healthcare costs continue to be a major threat to employers, employees, and our economy. As premiums and healthcare spending continue to rise at unprecedented rates, innovative solutions are needed that will provide higher quality healthcare at more affordable prices. As we've learned today, businesses are the innovators who can solve these challenges, not government mandates. By investing in new payment models like direct contracts, high-performance networks, and centers of excellence, the employers our witnesses represent have proved to be effective models for a new future in healthcare. Despite their successes, we know that there remain barriers for innovation in healthcare: access to data, overzealous state regulators, oppressive bureaucracy, administrative burdens, and accurately measuring performance remain challenges employers face in improving their health plans for their employees. We cannot afford to keep the status quo. It is our job in Congress to help expand innovative options broadly across the country. Congress can clarify ERISA's preemption to help insulate employers from overbearing state regulation. Congress can establish meaningful cost and quality benchmarks to help employers maximize their plan's values. And Congress can build off of the great work of the Education and Workforce Committee to strengthen healthcare price transparency and codify the transparency and coverage rule into law. I look forward to working with members of this committee to tackle these challenges. Again, I thank the witnesses for participating in today's hearing, and I yield back. There being no further business to come before the subcommittee, we stand adjourned.